going to be a short voiceover regarding the burns content. Burns are injuries to the tissues of the body either caused by heat, chemicals, electrical currents, or radiation. The highest fatality rates occur in children less than 4 years of age and adults older than 65 years of age. Burns are considered a preventable injury. The type of burns that will be discussed in this lecture are thermal, chemical, smoke inhalation, and electrical. Thermal burns are the most common type of burn injury, and they're either caused by flames, flashes of hot water or hot substances, scalds, or contact with hot objects like a stove. The severity of a thermal injury is going to depend on the temperature of the burning agent or the duration of time that contact has been made. Chemical burns occur with any kind of contact with acids, alkalis, and organic compounds. Alkali burns are hard to manage because they cause protein hydrolysis and liquefaction of the skin, and the damage continues long after the substance has been neutralized. Chemical burns can obviously affect the skin, but they can also affect the eyes, the respiratory tract, the liver, and the kidneys. In the event of a chemical burn, the substance should be quickly removed from the skin, and any clothing containing the chemical should be removed. The thing to remember with chemical burns is that tissue destruction may continue up to 72 hours after the injury. Smoke inhalation injuries are from inhalation of hot air or noxious chemicals, and they're going to cause damage to the respiratory tract, either the upper or lower, and it's considered a major predictor of mortality in patients with burns. It needs to be treated very quickly, and it can be broken down into injuries that include carbon monoxide poisoning, and as I mentioned before, upper airway or lower airway. So with carbon monoxide poisoning, carbon monoxide is produced by the incomplete combustion of burning materials. Inhaled carbon monoxide displaces oxygen. Our hemoglobin has a stronger affinity for carbon monoxide versus oxygen. So even though some of these patients have enough oxygen within their bloodstream, there's not enough that's attached to the hemoglobin because there's too much carbon monoxide. So it's displaced. So with carbon monoxide poison, you're going to see a relative hypoxia. And ultimately, death is going to occur with this type of poisoning in levels that are 20% or greater. So if a patient comes in and we suspect that they've had a carbon monoxide poisoning, we're going to treat them with 100% humidified oxygen. Carbon monoxide poisoning can also occur in any absence of burn injury to the skin. So upper airway injuries with burns can occur to the mouth, the oropharynx, and the larynx. It can be caused by hot air, steam, or smoke. So the swelling can be massive and can be rapid in onset. So the edema, the swelling, and the eschar, the necrotic tissue that can kind of form with these injuries, may compromise breathing or airway. So some of the signs that we might see in upper airway injuries or upper inhalation injuries with burns is the presence of facial burns, singed nasal hairs. The patient is going to have a difficult time speaking. Their voice is going to be hoarse. Painful swallowing. We might see darkened oral and nasal membranes, mucosa. Some of the sputum that they cough at might be darker in color. And some of the clothing that we see around their chest and neck is going to be burned. So this is actually a picture of a bronchoscopy that shows kind of the darkened oral and nasal membranes for the mucosa that's been singed and burned. So some of the lower airway injuries is going to be down in the lower part of the trachea, the bronchioles, and the alveoli. The injury is going to be related to the length of exposure to the smoke. So typically, two types of lower airway injuries can occur. ARDS or pneumonia. So usually ARDS, if that's going to happen, it's going to occur within 24 hours. And we also have a 10-day window that pneumonia can develop in somebody who's had lower airway smoke inhalation. This is just kind of a picture of the relationship between ARDS and pneumonia, although it's not a picture that really reflects the smoke inhalation in ARDS. It's just a picture just to kind of remind you of what ARDS is. It's the fluid that leaks into the alveoli that hardens. The alveoli become very fibrotic. And we also know that the alveolar cells decrease their production of surfactant with ARDS, and so we've got widespread collapse. So the hallmark, remember, of ARDS is refractory hypoxemia. So electrical burns can result from the coagulation necrosis caused by the intense heat generated from an electrical current. So it may result from the direct damage to nerves and vessels that cause tissue anoxia and death. So we need to remember with electrical burns, the severity of the injury is going to depend on the amount of voltage, the tissue resistance. Obviously, bones are going to have more resistance than like the blood vessels or the nerves. The current pathways, the surface area, and the duration of the flow. So current that passes through vital organs like our heart are going to produce more life-threatening sequelae with electrical burns. And in some cases, the electrical sparks may ignite patients' clothing, causing a thermal injury as well. So the severity of the injury can also sometimes be difficult to assess because some of the damage is actually internal versus external. And so that's referred to as the iceberg effect. We need to remember too, and this is an important component, that with electrical burns, sometimes the current is so severe that it can actually cause muscle spasms that fracture bones. And if patients are up on a ladder when they have electrocuted and they fall, we have to worry about head injuries. We have to worry about cervical neck injuries. So a lot of these patients, some of our priorities is going to be cervical stabilization of their neck. We also know because of the electrical current, and if it moves through the myocardium, these patients are at risk for dysrhythmias, ventricular tachycardia, fibrillation, and they can also be delayed. So even if they don't happen right away, it doesn't mean that they can't happen within days after the actual burn. So in addition to dysrhythmias, cardiac arrest, and the cervical injuries and the fractured bones, these patients are also going to be at risk for acute kidney injury from an acute tubular necrosis. With the massive amounts of tissue and muscle damage, we're going to have protein release of myoglobin from the muscle tissue. The myoglobin in excess quantities are going to be too big to pass through the renal tubules, and they can actually get clogged, leading to this AKI. So burns are going to be classified by four components: the depth of the burn, the extent of the burn, and the percentage of total body surface area, the location of the burn, and other additional patient risk factors such as comorbidities. So the depth of the burns, so we can break it down into first, second, third, or fourth. Superficial partial thickness, so these burns are going to be just through the epidermis. The deep partial thickness, these are going to be through the epidermis and the dermis. And then we know our full thickness burns, these are more of the third and fourth degree burns. They're going to be down farther past the epidermis, the dermis, all the way to the muscle bone. So this picture back here is more of an example of a partial thickness. And then right here, this is going to be a full thickness. So you see how it's kind of white, kind of waxy, a little bit of leather. All right, so that was the depth. Now the extent, so the total body surface area. So there are two assessment tools that we can use, but the most common one to be familiar with is the rule of nines. It's the easiest to use, and it's acceptable to use it as the initial assessment for total body surface area burned. And we know that we need to know the extent of the burn and total body surface area percentage because this allows us, I guess, to assess for mortality, severity, and it also gives us an idea of how much fluid these patients are going to need in the first 24 hours. So location. So obviously anybody who comes in and they've got facial, neck, or chest burns, we're concerned about respiratory compromise, whether it's to the actual chest cavity and the restriction if they start to have necrotic tissue or swelling or hardening around the chest cavity, or if it's going to be upper airway injuries, swelling, laryngeal edema, bronchoconstriction. When patients have burns to their hands, feet, or their eyes, we worry about self-care. We worry about contractures in the rehabilitation phase. And then we also worry just about overall self-management, gross, fine motor skills, the ability to ambulate, so self-care. And then any of those kind of more private areas like the perineal and the buttocks, when there's burns there, you worry about infection, with urination, having bowel movements. So the location again. So we also worry about severe burns to our upper extremities, lower extremities. So anything that has a circumferential burn, so it's around the entire circumference of a limb, if it becomes swollen, it becomes very hardened, the tissue becomes very restricted. It's almost kind of like a tourniquet or a tamponade around the extremity. So we worry about a condition known as compartment syndrome. So the swelling and the resistance around the extremity can become so severe that it actually compromises neurovascular status distal to the injury. So sometimes the swelling becomes so severe that they lose their pulses. They lose all arterial circulation, blood flow to the distal portion. So if a patient has such severe edema that they lose a pulse, the extremity becomes pale, painful, cool to the touch, mottled, this is kind of a medical emergency, and we're going to have to reach out to the physician or the healthcare provider. And some cases, I think with burns, it's going to be referred to as an eschorotomy or escharotomy. But there are other conditions where compartment syndrome can occur with fractures, crushing injuries, motor vehicle accidents. In that case, they're going to be doing what's known as a fasciotomy, where they cut right through the skin, right through the dermis, the fascia, all the way down to the muscle, to kind of open up that area and to relieve that pressure to allow circulation to get back down to the distal portion. So another thing to consider with burns is risk factors. Obviously, if patients have concurrent fractures, head injuries, cervical spine issues, their recovery is going to be more difficult and their mortality is going to be higher. Patients who will already have immune compromise, diabetes mellitus, existing peripheral vascular disease, these patients are going to have poor outcomes. And then if our patients come in and they have a history of alcoholism, drug abuse, and malnutrition, well, they're already behind the 8 ball as far as wound healing, infection prevention. So the phases of burn management can be broken down into emergent, which from a critical care standpoint you need to focus on, acute, and the rehab or the restorative phase. So pre-hospital care, obviously these patients need to be removed from the source of the burning, and we need to stop the burning process. And if you're the rescuer, you need to make sure that you don't become the victim. So we need to remove the patient from the source, and we also have to remove the patient from contact with the source. So removing any clothing or jewelry that may be on the patient, rings if the patient starts to have swelling, because a lot of that swelling and edema can occur within like 20 minutes of the actual injury. So we need to be cognizant of watches, jewelry, necklaces, any restrictive clothing bands. If it's a chemical injury and it's dry, we might consider kind of brushing some of the particles off. And if it's appropriate, like if it's an alkali substance, we're going to use water to lavage the area. Obviously, with anything else, we're going to focus on airway, breathing, and circulation. If we feel that respiratory is being compromised, it's important not to delay intubation, because sometimes when the laryngeal edema becomes so severe, they may have lost the opportunity to intubate these patients successfully. And in some cases, they may have to trach them or crag them because the swelling has gotten so severe. Like we said, removing the burned clothing, especially with the deeper, the fuller thickness burns, we need to wrap these patients in clean, dry sheets. We mentioned observe for signs of respiratory distress, and then treat quickly and efficiently. We talked about that. And if we suspect that patients have carbon monoxide poisoning, we want to make sure that they get 100% humidified oxygen. So the emergent phase, this is going to be the phase that occurs up to 72 hours post-injury. And our primary concerns are hypovolemic shock, fluid loss, electrolyte imbalances, and massive edema. Okay. So the greatest threat, obviously, is the hypovolemic shock, the burn shock. Initially, this is going to be caused by the increased capillary permeability, and we're going to see massive fluid shifts out of the blood vessels into the interstitial space. This is referred to as second spacing. We're also going to see some of the albumin leak out as well. So this is going to not only we're going to have fluid leak out, but if we're having albumin leak out of our vascular space, we're going to have a reduction in that oncotic pressure, the colloidal osmotic pressure. So we're losing fluid in two different ways, right? The albumin actually has a pulling pressure, and if it's outside the blood vessels, it's going to be pulling additional fluid. And so this is just a look of a patient, and we know that these patients are going to swell, but it's not in the appropriate places, the fluid. So we still have to volume resuscitate them despite the fact that they're gonna swell, because we need to maintain circulating volume. Okay. So in the emergent phase, normal and sensible loss in a healthy person is somewhere between 30 to 50 mLs per hour. In a burned patient, you're going to see it somewhere between 200 to 400 milliliters per hour. So, like we said, these patients, hypovolemic shock, burn shock, they're obviously going to have low blood pressure, reflex tachycardia. Something else that we're also going to see is that these patients are going to have an elevated hematocrit. It's going to be a relative rise. It's going to be because the fluids have left the vascular space. So the plasma's left the vascular space, so we've got a rise in the RBC. So we're going to see an increase in hemoglobin and hematocrit, but it's going to be a relative, because we're actually going to see during the time of burns that the RBCs are going to be hemolyzed, okay, at the time of the injury. So even though when we check a blood sample during this time, our RBCs are going to be elevated, we're going to have hemoconcentration. Once fluid status stabilizes and the fluid moves back into the vasculature space, we're going to see an anemia. Okay, so initially we're going to see hemoconcentration, but after fluid volume resuscitation, after the volume stabilizes back into the vascular space, we're going to see a drop in RBCs, so they're going to be anemic. So sometimes they may need blood resuscitation. Initially, when they do have an elevation in their hematocrit, hemoglobin, that viscosity, that increased viscous substance, it increases the risk for thrombosis, so clot formation. We're also going to see the sodium rush out of the vascular space initially in the emergent phase. So these patients are at risk for hyponatremia. Similar to what we talked about with the myoglobin, the release of proteins from the muscle, the tissues of the muscle, we saw the myoglobin get kind of caught within the renal tubules of our kidneys. We're also going to see the release of potassium from our cells, okay, with the tissue damage from the burns, especially with massive tissue loss. Because potassium, the major place it is intracellularly. So when we have tissue damage, cellular damage, we're going to see a rise in potassium level. So we're also going to see problems with immunocompromission, okay? Not only is our first line of defense, the skin barrier, destroyed, we're also going to see depression of bone marrow, okay? So a decrease in lymphocyte production. We're also going to see a reduction in immunoglobulins or antibodies, okay? We're also going to see some defects or alterations with the white blood cells that exist that are circulating. So in addition to the loss of skin integrity, these patients also have additional composition to their immune system. So we talked shock from the hypovolemia, so the clinical manifestations, obviously low blood pressure, tachycardia. Sometimes if we have such hyperperfusion, we're going to have hypoperfusion to the gut, so these patients can have a paralytic ileus, right? So if they're in shock, they're going to maintain circulation to the center or to the more important organs, and they're going to shunt from the periphery. We might see shivering because these patients have lost, especially with increased percentage of total body surface area and depth, these patients have lost a lot of insulation, so they're shivering to try and attempt to generate heat. Altered mental status, especially if their blood pressure is low, they're hypovolemic, and also if they have some of these upper or lower airway injuries. If we see a patient come in with altered mental status and they've got neck, face, upper chest burns, my concern is for hypoxia. So I'm going to be checking a pulse ox. I'm going to be assessing their respiratory status, auscultating their lungs. Dysrhythmias, we talked about ventricular dysrhythmias, VTAC, VFib, cardiac arrest, and we know that the risk for the dysrhythmias is long. It's not even in the initial emergent phases. We talked about impaired circulation to the extremities in the event if it's a circumferential injury. So even if it's not the circumferential injury, in the initial phase where they have hemoconcentration and they're at increased risk for thrombosis, we can see tissue ischemia, paresthesias, and necrosis to the distal portions of the extremities. So I think at some point, the existing extremities, we're going to be assessing pulses and neurovascular status. This is a picture of a person who's got a burn injury to the chest, and they had the escharotomies as a result of the compartment syndrome from the swelling, the charred skin that became very hard and leathered that lost its ability to compromise. Okay. So we talked about upper and lower airway burns because of the laryngeal edema, the edema formation increases their risk for obstruction and asphyxia. We talked about the risk for lower airway injuries. Pneumonia can happen over a week out, and the pulmonary edema or ARDS, we know it's a non-cardiogenic pulmonary edema. Smoke inhalation is a #1 risk factor for ARDS. We talked about the patients at risk for acute tubular necrosis secondary to the myoglobin release from muscle tissue damage. This might be a picture of somebody who not only is in renal failure but has high levels of myoglobin in the kidneys or in the urine output. This is what this looks like. So some of the collaborative management, we're going to consider early endotracheal intubation with mechanical ventilation in some of those patients who have got upper and lower airway injuries. Okay? Their SATs drop, their respiratory status becomes compromised. We worry about losing their airway. we are going to intubate. Escharotomies of the chest wall, okay, if it's compromising their respiratory status. And in some cases, if we want to assess the lower airway to assess the damage, we might consider a bronchoscopy. But we have to worry about bronchoscopies because if we're sticking an instrument or a device down the airway, we can actually cause more swelling, more injury. So it's something to consider. Humidified oxygen at 100%, right? Especially if there's CO2, carbon monoxide poisoning. Some other things to consider for our nursing interventions, if these patients come in, we're not necessarily intubating them, we're going to keep them up in a high Fowler's position. We are going to focus on coughing and deep breathing every 1 to 2 hours, turning, frequent movement in bed, CPT, so postural drainage when appropriate, if applicable. We're obviously going to make sure that these patients have adequate IV access to large bore IVs. If there's a substantial burn, total body surface area, and if it's applicable, we might have to put a central line in these patients. Okay? And we know we're going to be using the Parkland formula for fluid replacement over the 24-hour period. So please be familiar with that. We know that once we calculate how much fluid needs to be administered over a 24-hour period, we give 50% within 8 hours, and we give the additional 50% over the next 16 hours. The fluids that we like to use are lactated ringers, which is a colloid, or a crystalloid, or we can use a little bit of albumin, which is considered a colloid. Okay. So wound care should be delayed until the patient's airway breathing circulation has been established. That's our priority. So wound care, so cleansing can be done in the cart shower, or bed. We need to consider debridement. It can be done in the OR, it can be done at the bedside, and it's something that's going to be done to continue to remove that necrotic skin so that tissue regeneration and growth can start. We know we need a clean surface, clean slate. Just a picture of a hydrotherapy cart shower. Just a picture of debriding of a full thickness burn. All right, so these patients, usually they're going to be showering daily. Okay? They can have dressing changes twice a day, morning and evening. We know infection is the most serious threat to further tissue injury, and sometimes the source can be directly from the patient's own flora, from maybe a different location on the body, their respiratory tract, their GI, GU. So the open method of wound care, the burn is going to be covered with a topical antibiotic, but with no dressing over the wound. These patients are going to have multiple dressing changes or closed method. And so those patients are going to have a sterilized gauze dressing that's laid over the topical antibiotic. So dressings can be changed from every 12 to 24 hours to once every 14 days. So we need to remember too, in order to prevent cross-contamination from other patients, that staff need to make sure they're wearing the appropriate personal protective equipment, right? We said infection is a big risk factor with these patients, with the deeper the total body surface area burns. So making sure the hats, the masks, the gowns, and the gloves. So we can use allografts or homograft skin, and these can be usually from cadavers, and they're going to be used with newer biosynthetic options. So facial care is going to be performed by the open method. We're going to see eye care for corneal burns, and typically with antibiotic ointment. So in order to help prevent contractures, limitations in the rehabilitation phase, anybody who has hands or arm burns, they should be extended and elevated on pillows or support. supported with slings. We need to make sure that we keep anybody who has like burns to the ears should be kept free of pressure. And if they've got neck burns, we need to make sure that we are not using pillows on these patients to prevent contractures. Because they're at risk for translocation of bacteria, the normal flora, we need to make sure we're keeping the perineum as clean and dry as possible, especially if there's burns to those areas. In the beginning, we're going to be making sure we've got a Foley catheter inserted, but good peri care. So drug therapy, we know we're going to be using IV narcotics. We're not going to be using IM. In some cases, we may be able to use a PCA, but IV morphine or IV Dilaudid. We might consider adding a sedative, amnesic if we need to in combination with the patient, not only for the synergistic effects, but also if there's a lot of anxiety, agitation associated with the dressing changes. And then if our patients have not had a tetanus within the last 10 years, or if it's been close to it, they're going to be given a tetanus immunization. So some other drug therapies to consider, like some of the topical agents that we're going to use with these patients who've got burn, Silvadene. Typically, systemic agents, antibiotics, are not usually used empirically to control like the burn flora. They're only going to be initiated when there's truly a diagnosis of sepsis.